Okay, I think we're going to get started. I know there's a few people in the back, but I think everyone has their meals and are seated. So my name is Brian Byrd. I'm the program officer for the Special Projects Fund here at the New York State Health Foundation. And a couple of housekeeping items. The men's room, straight back. The women's room, you can go to the right past the receptionist desk. Then off to your left is the women's room. Please set all of your cell phones on silent or off. And if you're like myself, if you have an iWatch, please set that on silent as well, because it will go off, which has happened to me once at a very inopportune moment. And I think that should be it. We also want to welcome our audience on Facebook Live. This is the second time that we're doing this, so we're live streaming this event. So hopefully no technical glitches, and everything will go well, and that they were able to hear us as well. The purpose of this event, as you can tell from the title, that's coming up, the title of it is A Conversation on Innovations in Monitoring Population Health. I think it's actually a very timely topic. And we have two people here to talk about projects that they're working on. Immediately to my left, is David Lee. David is on the faculty of the Department of Emergency Medicine and Population Health at the NYU School of Medicine. His research uses big data in the form of large-scale administrative claims databases and geospatial analysis to analyze patterns of healthcare among millions of emergency department users. And we like the idea that geospatial analysis gives that very science fiction almost component to his work. And next to him is Lorna Thorpe, who is professor of epidemiology and director of the epidemiology division at the, again, New York University School of Medicine in the Department of Population Health. And her current research focuses on the intersection between epidemiology and policy, mostly with respect to chronic disease prevention and management and improving modern forms of public health surveillance. So the purpose of this is really to spotlight two particular projects that has been getting a lot of attention. There was, I think we all met at a meeting down in Washington, D.C. Was it the Academy of Health? Back in January of this year, when I first heard about the projects that they're working on, and I thought this was really exciting, and we should bring what I learned and heard in Washington, D.C. and bring it to New York. So with that introduction, I think what we'll do is I'll have David kick it off and talk a little bit about his work, and then Lorna will talk a little bit about her work. And then after that, I'll ask a couple of questions, and then from there, we'll open it up to the audience for questions as well. So with that, I turn it over to David.
Yeah, so I just wanted to thank everyone here for coming, and also the New York State Health Foundation for just inviting us here, and also funding part of our work. It's just a really exciting time to be here. As Brian said, I am an ER doc, so if you call 911, you'll probably be shipped to one of the either New York University Hospital or Bellevue Hospital, so you might see me in the emergency department. So if I look familiar to any of you, that might be where that's coming from. But I guess I got interested in health surveillance because, I work in an ER, and essentially that's the safety net of our healthcare system. And so many of the public health problems that we have in the U.S. are seen by me. And so each person that comes to the ER can represent a public health problem, and many of them I felt were intractable, especially chronic disease. Even though I'm a doctor, there's very limited things that I can do for people with chronic disease when they come in with uncontrolled hypertension or uncontrolled diabetes. And so that's sort of the genesis of where I got interested in it. And I think the most particular question that I thought need to be addressed is, what's the geographic distribution of these things? I got really interested in GIS and mapping, and basically wanted to identify where are the hot spots in the particular neighborhoods that we can track down of where the disease is just overwhelming. And so the problem is that basically your traditional methods of health surveillance are limited by small sample sizes. Basically, the New York City Department of Health does this great citywide health survey, the community health survey, that samples like 9,000 individuals in New York. And that's a very difficult survey to do because it's telephone-based and it's actually a really large sample of people. But when you compare 9,000 to the 6.4 million New Yorkers, it feels a bit small, and the ability to say what is the geographic distribution of disease is a bit limited. And so sort of one of the solutions that we have been developing and have developed and continuing to validate is to use existing large-scale databases and data sources and use geospatial analysis to identify the local prevalence of chronic diseases like diabetes, hypertension, and asthma. And so basically we call this at NYU emergency department surveillance. And we basically use emergency claims data to identify local hotspots of disease. Now you might wonder why emergency data, and it turns out that actually a lot of people go to the ER. I actually feel like that every shift. and if you ask, and the CDC has asked, like if you ask 5 people in the US, 5 American adults, did you go to the ER last year? And one of them will say yes. So that's a 20% population sample, like unique individuals, because actually per capita there are like 500 ER visits per every 1,000 people in the US. So it's just a like large database, and this data is already collected. Every state, or at least 27 of them, have already systems in place to collect this data, and it's sitting there to be analyzed. And so what we've done is we've analyzed it, try to identify people who repeatedly go to the ER, and then track them down by individuals and say, does that individual ever have a history of diabetes, hypertension, or diabetes, or asthma that shows up in the claims diagnoses? And then we can basically track what the prevalence of diabetes, hypertension, asthma is. The nice part of the New York State health data that I have, which is basically millions of ER visits, is we have the home address of everybody. So we have the XY coordinates to say where everybody lives. And I guess the reason why this is important is because the geographic detail that you're able to see is much larger or much more granular. And so this is like the New York Community Health Survey. Over a 4-year period, they'll collect survey results from about 36,000 individuals, which is a lot for a telephone-based survey. And this is the geographic granularity that you can basically estimate what diabetes is. And so darker shades would be diabetes, higher diabetes prevalence. And so these are the UHF neighborhoods. It cuts up New York City into 42 areas. And you can see that, you know, if you guys New York City, like each of these UHF neighborhoods is incredibly complex. I would argue almost block to block. There are differences in what the socioeconomics are and the demographics are. So what can you do with ER data? Well, if you take 4 years of ER data and you stack that 20% sample and you account for all the repeated ER use and you look among unique individuals, with just 4 years of data, you'll get over 4 million records of unique individuals and data for all of their health conditions that show up in the emergency claims database. Now, this is 2/3 of the entire adult population of New York City. And it's 4 years of data that's just sitting there. And we have the home addresses for everyone. And so what we can do is we can start cutting it up at a more granular level. So this is a census tract level analysis where you basically see where the pockets of diabetes is much higher. And so naturally where you might see, if I could get this laser pointer to work, in Manhattan, lower Manhattan, you might say, well, diabetes prevalence isn't so bad. It's like 8% or 6% down here, and so that's actually lower than average. But if you look at the more detailed analysis, these 3 census tracts right here by the bridges down there have as high a diabetes prevalence as anywhere else in the city. And so the thing is, when you have a small sample size, you miss these things because you're averaging this out. And that can be incredibly important because what is going on in that area that makes it such that the diabetes is so prevalent? And so basically we've validated this work, at least shown that our estimates at the neighborhood level, going back to this slide, actually correlate really well for conditions like diabetes, hypertension, and asthma. In New York City, you have this sort of gold standard to compare. The traditional health survey is still considered the gold standard, and we see that our diabetes, hypertension, and asthma estimates line up pretty well. And so this sort of turns into me discussing what our grant-funded project is with the New York State Health Foundation. And the thing is, in a city like New York City, where there's this incredible Department of Health and Mental Hygiene that can do health surveillance, it's helpful to know what the distribution is a little bit more geographically. The thing is, they have a lot of resources to tackle the problems. Now you turn to somewhere like Sullivan County, right? And that's where we've partnered with the Public Health Service there. And I don't know if you're familiar with Sullivan County, but it's a rural county located in the Catskills Mountains in southern New York State. It's just about 2 hours away from here. It's very rural. About 80% of its residents are rural. And it's been ranked 61st out of 62 New York counties by the county health rankings. Now that has been consistent for the last 6 years, right? They're second in health outcomes to the Bronx, and that's it. Otherwise, they have the worst health outcomes in the state. And so you imagine the problems that are in the Bronx that we're all familiar with, and there are just a depth of problems there in Sullivan County. And they also have the highest rate of premature death in the entire state of New York. So the thing is that my partner there, the Sullivan County Public Health Service, their mission is to prevent illness and disease, to protect and promote public health for the residents of their county. But their budget is so much smaller, as you can imagine, because they're a rural county and they just don't have as many resources. You have this relatively small group of dedicated civil servants. I've met a lot of them and they're great. And they're really dedicated to improving health there. But what are the programs that they have to do? Well, they have to run the county's home health agency. They have to coordinate long-term home health care. They have to run a child safety seat program. They have to address the needs of physically handicapped children in the county. They're running the early intervention program for children, and they're running the WIC program for the entire county. So you imagine, with their limited budget, what time is there to do health surveillance there? And the answer is, when we talked about it with them, it's not a lot of bandwidth, although they do it as best they can. And so basically we asked this question: can we take this emergency department surveillance and transfer that to Sullivan County and do hot spotting of disease there? Now, the CDC does health surveillance in Sullivan County, but every year they analyze records. They survey about 40 to 50 residents in the entire county. Now, they're like 60,000 adult residents, and they're talking to like 40 or 50. And so they can only give this like gross approximation of what diabetes prevalence or hypertension prevalence is in the county. So let's say it's like 8% countywide. But the thing is, what we've done with the ER data is said, well, if you take 3 or 4 years of ER data, we can track records for 40% of the entire adult population in Sullivan County. We have their home addresses. And so here's the prevalence of diabetes in Sullivan County based on our emergency department surveillance. So this is tracking 40% of the individuals who live there. And so our work with the foundation is basically to validate the use of this surveillance system. So what we're going to do is, there's no gold standard to compare this with, and so we're going to actually do a gold standard comparison. We're going to do, actually we already started, we start to make the telephone calls, start to mail the surveys, and starting to plan for the in-person surveys, where we're going to geographically target various zip codes in the county and try to identify what the prevalence pattern is and see if that aligns up to what we're seeing in the emergency department data. And I think also another part of the project is basically to support the Sullivan County Public Health Service by providing capacity for geospatial analysis to identify these areas that have high health needs. And so that's our plans for the work. We've implemented that, and we really think we can make a difference, because it's a county that has an exceeding amount of health problems, has very poor health outcomes, and they could use these data-driven approaches to basically target those populations which are at highest need.
Great. Now, Lorna, you're sort of focusing more on New York City, and you were working as part of a team, if I remember correctly, with the New York City macroscope. So why don't you talk a bit about that project and how it's similar and how it's different, how it differs with what David was talking about.
Sure. And just to go back to your introduction, I am an applied epidemiologist. My prior career, I was at the New York City Health Department, and my work does focus predominantly on the prevention and management of chronic diseases, and I do that in 3 different ways. One way is designing epidemiologic studies to evaluate policies and their impact on chronic disease prevention and management. Another is testing community clinical linkage models to improve the management of chronic diseases using community health workers, electronic health record interventions, and I have colleagues in the audience that I do that work with. And the third area that I focus on is this innovation in surveillance. And this is an area that I'm very interested in from my prior public health practice experience. And I think the time now it's a very important time to think about retooling some of our methods to harness the promise of big data, to improve our ability to do small area estimation, like David showed so nicely, to capture novel data streams and use new methods and new metrics. And so it's in that category that this project, the New York City Macroscope, falls. And it's a full partnership with the New York City Health Department. We got our start from the New York State Health Foundation with in 2 ways, actually, back in late 2011, 2012. The first was the more traditional formal way. We got a fantastic planning grant from New York State Health Foundation. It was really that planning grant that allowed us to map out the vision of what we wanted to achieve over the next 5 to 6 years. The second, with the support of then Jim Nickman, who is here, he encouraged us to convene, and he actually helped us convene a number of foundations and get together in a room and really talk about that vision. And it was through that support and suggestion from New York State Health Foundation that this project was really launched. And what we launched was twofold. First, we had long wanted to do another population-based health survey. In 2004, we had done a survey that didn't use telephones. We went to the homes of New Yorkers. We used what's called a household-based sample, and we performed not only a health interview, but a clinical exam, a physical exam, and we took blood and urine, so sort of a doctor checkup on New York City to really understand how many New Yorkers have the chronic conditions that we're concerned about that are common and leading causes of morbidity and mortality. How many of them know that they have it? So we wanted to know diagnosed and undiagnosed conditions, and we wanted to know how well people were doing at managing those conditions. And those are things that are not easy to get from a telephone survey. And so back in 2004, before all of this, we had done a major survey called New York City Hanes, and it was a massive effort. But we did it, and we learned how many New Yorkers had hypertension, diabetes, high cholesterol, and a number of other things. We wanted to do a second one 10 years later. That was already, we knew, going to be expensive and difficult to do, and response rates to surveys, both telephone and non-telephone, around the country are declining. So we knew that this would be hard. But what we also wanted to do was to test a novel way to collect that same information on how well are we managing conditions, diagnosed and undiagnosed conditions. So we wanted the clinical information. And I credit Tom Farley at the time, then health commissioner here in New York City. He suggested that we try to do this by tapping into electronic health record networks. And so the planning grant and then the subsequent consortium of foundations, New York State Health Foundation, de Beaumont Foundation, Robert Wood Johnson, and ultimately Robin Hood Foundation supported us to perform that New York City Hanes population-based survey again, and at the same time design a new surveillance system using electronic health records, and to use the Hanes survey as the gold standard. David mentioned gold standards. To use that as the gold standard to validate whether or not we can learn about, with validity, meaning with accuracy, whether we can learn what we would learn from these large population health surveys, from data that was already being collected in EHRs. And so we knew that at the time there was a lot of interest in doing things using electronic health records for population-based purposes, population health purposes, but there's also a lot of skepticism, and we shared that skepticism at the time. What would the quality of the data be like? Don't EHRs only represent people who are in care? What about people who are not in care? And these are non-representative samples of clinical providers, so how will we make this represent the totality of people who either are in care or the total population? And so we set out, and I'm just going to, in about 1 minute, go through the steps of what we did, and then I'll step back and talk about what we learned. We first convened a scientific advisory board with experts from around the country, because what we wanted to build, we wanted it to be informative not only to New York City, but to other health jurisdictions as well. We put time into defining what indicators we wanted to extract from the electronic health record system. And then we published a planning document to say this is what we intend to do and this is how we will analyze it and compare it. So we sort of affixed our thoughts in paper and publicly first. We spent some time thinking about inclusion and exclusion criteria. And I'll come back to that in a moment when I describe the electronic health record network. And then we performed the survey. And then we tested queries of how we would extract the information from the electronic health record. And then we compared the data between the survey and what we extracted from the record. So we used the year 2013, and we compared the health of New Yorkers from the New York City Haines survey to the health of New Yorkers from this EHR network. And then the findings of which were published in just late last year, 2016. The electronic health record network that we used is a network of primary care providers that is overseen by the New York City Health Department. Many people in the room may be familiar with it if you work in this sphere. It's called Primary Care Information Project, and that is a project that started out by providing technical assistance and with government-subsidized EHRs to primary care practices across New York City, predominantly small primary care practices. And the main purpose was for quality improvement in clinical care. But this project was coming around and using that network for population health surveillance purposes. And so what we could obtain from this network was not individual line level information about every patient, but we could obtain information at the practice level. So it's what we call aggregate data, where we could get information about how many people of a particular age group, gender, makeup had a condition and how many patients were in that group overall. So a proportion per practice that we could aggregate up. And so the question that we were very interested in was, with a very large non-representative sample of clinical practices, and we ultimately used about 400 practices that represented about 17% of the New York City population in care. David's represented 20%, so this is comparable. This was 17% of people in New York City who had seen a doctor in the last year. With a non-representative sample, can we collect information that's good enough quality, and could we statistically weight it to give us information about how many people in New York City have these conditions? And the upshot of our findings were, for some indicators, yes, they're ready. They work in macroscope, and we did some additional validation to see whether they could work in electronic health records that were not represented in this network as well. The conditions that worked well are, what's the prevalence of hypertension, diabetes, obesity, smoking? These all worked fairly well. For other conditions, not quite yet, for a number of reasons. Depression didn't work well. Didn't work well largely because primary care providers don't routinely screen for depression, and if they do screen for depression, they may not document it very well. So depression worked poorly. Screening for influenza vaccination worked poorly, predominantly because people don't always get their vaccine in a doctor's office. And then our real hope of being able to carefully monitor how many people with chronic conditions are being well managed doesn't work very well just yet. And it doesn't work very well for a number of reasons, but we think that the main reason is that the practices that we were working with were receiving a lot of quality assurance and support around disease management. And so they didn't represent the average. They were, in many respects, doing better than the average. So we had systematic biases in the network of providers that we were reaching out to. What we think is, and so there's a lot of work still ongoing with this. The New York City Health Department led this side of the project, and I led the New York City Haynes side of the project, and they were built together side by side and compared side by side. What we're doing now with Macroscope, and I say we broadly, but I really credit that a lot of the work is happening at the health department, is examining how well we can monitor trends over time, because as EHRs are increasingly being used, and as doctors and other parts of the clinical team get better at documenting over time, there may be data artifacts that are changing that are not real changes over time in burden of disease. Similarly, as more people or less people are insured over time, that may change the denominator of who's in care. And so if that's in flux, which it is, then there may be challenges in really accurately monitoring what is a true increase in disease burden. And so we're looking into trends, examining some new indicators. The health department's working on a child module. We're trying to understand better missing data and some of the biases that I mentioned. We think that in general, what we learned is if it's measured well in the electronic health record, then with statistical weighting, with a large sample, it does work to represent the health of a community. And so that's very important work, and I think it's a comparable lesson learned to what David just described. Electronic health records provide us with near real-time information. They're very large samples, so that allows us to do a number of things like small area estimation, potentially, looking at rare conditions, looking at conditions in small populations, so the oldest old, or race ethnic groups that are usually too small to represent accurately in telephone surveys or other surveys. We may be able to learn about their unique health profile. And it's an interesting time now in the world of electronic health records. So the largest electronic health records around the country are health information exchanges, and their primary purpose is to improve care by exchanging information. If I'm seen by my primary care provider today, and then I'm in the emergency room next week, my primary care provider can hypothetically know that information because of the health information exchange. Well, health information exchanges are large, many of them, and they are beginning to be interested in population health now. And there are other electronic health record networks here in New York City. There's one called the Clinical Data Research Network, very large, used predominantly for academic clinical trials. This is a sphere that is beginning to be interested in using the same data for population health. So with that, I'll turn it back to a conversation.
Sure. You know, one of the things that I've, as I'm listening to the two of you talk, the electronic health records are really key in the work that the two of you are doing, and they seem to be key as far as health population surveillance. But we also are living in an age of privacy and too much information. So how do you balance, when David was saying that we actually know what street they're living on versus, and as well as with the work that you're doing, how do you balance that? How do you figure out where do you draw the line where you don't go over the privacy issue? Mm-hmm. I mean, I was actually surprised when you said that you would actually know what block I would live in if I had used an emergency room or something like that. So how do you manage that? Are there ways, or are there procedures or firewalls in place to avoid that?
Mm-hmm. Well, specifically with our work, we obviously have an institutional review board that reviews all our practices. But at the same time, I would say, this geographic research is basically increasing in complexity and increasing in use. And so I'll tell you, some of my GIS colleagues will sit on one side of the fence. They'll be like, basically, well, it's okay. I mean, we'll be a little bit more liberal about things. And then other people sit more conservatively. I tend to be more on the conservative side because I understand, this is an incredible amount of data and there's incredibly sensitive issues at play. Some of the techniques that we use is obviously there are strict protections of where this data is held. We have data use agreements that we are bound to live by. And then any sort of data representation that we do is always an aggregation of many individuals so that you couldn't identify any one particular individual. And even if you were to show like point data, like XY point data in a GIS map, you could always what's known as jitter the addresses, which is you add a random like half mile or quarter mile to the address point to basically mask that person's location. I would say that it's still an emerging field, and it's almost like the GIS research has outpaced like sort of that protections issue. But I would say that our group really tries to abide by the idea that this is very delicate information that needs to be handled the correct way.
Lorna?
I have two other thoughts. One is, it's interesting to note that one of the compelling attributes of macroscope is that it's not individual level data. And so the health department doesn't receive any information about patient X. It receives aggregate data that cannot be identified. And so here's a model that the health department has led that is potentially attractive to other jurisdictions or entities that are concerned about that. Mm-hmm. And the other thing that is often a potential a solution to this issue is to identify the critical honest broker. And I think in this day and age in surveillance, we are in a world of collective analytics. We need to bring together information from multiple institutions to be really able to understand who lives here, what the healthcare status is, what the community conditions are. And it may be that one honest broker, whether it's the census or a health department or a third party, handles the sensitive information, but that the key stakeholders are engaged in the development and use of those data, but don't touch it.
Mm-hmm. Well, it's funny because I read an article in the Harvard, not to blindside you on this, but I did read an article in the Harvard Business Review. It was by Dr. Sandro Galea. And he commented that most of the monitoring focuses on a group as a whole, and that it's kind of is so you're basically serving and addressing sort of the low-hanging fruit because of that. And some of the shortcomings of that is the fact that they're not getting down into the individual communities, so they're not getting into the real marginalized communities. So a lot of the responses is kind of very broad-based and doesn't necessarily help those that need it the most. So, thoughts?
I'll take this one. Sandro's a friend. And I wholeheartedly agree with him. I think part of what both David and I are proposing here, or these projects and our partners, what we're proposing here are solutions to dig deeper. So when I started at the New York City Health Department in 2002, I was struggling to put together a valid estimate for smoking for the city. Mm-hmm. We had to use state data to understand what the smoking prevalence in New York City was. And the state performed a survey with a couple of thousand people statewide. Mm-hmm. That's a reality for many states and many counties and many cities in New York City. Now, New York City Health Department, because it put the investment into really trying to understand the health of communities at a more granular level, we can say with accuracy that certain communities in whether it's East Harlem or in Sunset Park have high levels of diabetes or poorly controlled hypertension. And that's critically important, both geographically but also through other stratifications. And I think socioeconomic stratifications are in many respects the factors that are driving the development of disease in the first place.
Yeah, so I think sort of this brings up like a whole host of issues for me. I think really the way that I think about it is we're reaching this era where we desperately need what I like to call precision public health, where basically, you talk about precision medicine, where you have this tailored medical treatment that, analyzes your DNA and you're able to like treat all the gene therapy, blah, blah. But at the end of the day, some of the most pressing problems are basically not something bound up by genetics, but often health behaviors and the community attributes of where you live. And so I think, sort of these geographic approaches to understanding public health are important. I would say it's even more important, especially in this sort of era where we're constantly talking about healthcare costs, right? 1 in every $5 of the GDP is spent on healthcare. And so why do we not see the health outcomes that should align with the amount of money that we're spending? And I would say that's largely because the health system itself is not aligned to what is needed in terms of population health. You have your average person who comes to the ER frequently for uncontrolled diabetes, and that person might be a 52-year-old male who has 3 jobs, can't get to the doctor, every week, and managing their blood sugar is very difficult. Checking their blood sugars 3 times a day, taking 4 different medications. I have a hard enough time taking 1 medication and remembering to do that, and I'm a doctor, right? And so there's this kind of misalignment where our health system requires that individual, if they came to the doctor's office and said, I have a diabetic foot ulcer, what can you help me with, because I'm trying to get to work on time and this is preventing me from getting work on time. Well, the health system's response is, well, I need you to see a podiatrist. So that's going to be a different visit on a different day. Oh, and by the way, I noticed that your blood pressure is higher today, so we're going to give you another medication. And you should be eating better. So let me send you to a nutritionist who's going to be another visit on another day. And it just doesn't take into consideration that person's life, right? And what are the circumstances there? And so some of our other research is to identify these neighborhoods and then actually do qualitative interviews in those neighborhoods. Like, the quantitative data tells you where the problems are. It probably doesn't tell you what is driving the problem. And so we're going to basically do these focused, targeted, geographically targeted interviews in these hot spots of diabetes and ask questions of those people's lives. Like, how can we help you? Like, what's the exact problem here that we can address, and how can we do that in the context of your own life? And I think that's something that I think about constantly as a doctor, because I'm just not sure that our health system has been trained to think like that.
So you have all this information, and you now know where the shortcomings are. How do you implement it? I mean, how do you address it? I mean, if you know what the problems are, that, let's say, they're not getting the right food, they're not eating properly because the food is just not available, or things like that. And I think specifically like some of the poorer neighborhoods in counties like Sullivan County. Once you have all this information, then what? How do you actually make it happen?
So
I know it's another elephant in the room.
That's definitely like, I would say, like, identifying those areas is the first, I would say, baby step in solving the problem, but a critical one, of course. But those questions are much deeper and much more complicated. And I would say that's because most people's lives that have uncontrolled chronic diseases, their lives are such that, there's a staggering issue of it's almost like, how do you solve poverty? Or how do you solve a lot of these things? But I really think there are some incremental differences that you could make in people's lives. I go back and forth with my wife about this. I'm like, so there's a food desert here, or they don't have access to fresh foods, or there's too many fast food restaurants. How can I deliver them this healthy food option? And I guess I think about it with my wife, and I have 3 young kids. I have if you look at me just socioeconomically, I'm doing okay, and I have trouble feeding my kids healthy food options. And so I think there needs to be a lot of innovation around what we're going to do. The issue comes with, are those going to be politically viable options? And I'm not so certain some of them will be, but hopefully a good number of them would.
Lorna?
So I have a philosophy that surveillance is as I think you're both expressing, it's really step one. And I never look at data without trying. It doesn't tell the story. It frames the story that you have to tell. So surveillance is very action oriented. And we should never lose sight of that. And so some of the information we learned from the population health surveys that we were doing that had the clinical information was used for policymaking, and that's a nice sweet spot if we can do that. We learned from the first New York City Hanes that even though we smoked less in New York City than the national average, we had higher levels of cotinine in our blood, which reflects that we were getting exposed to a lot more secondhand smoke exposure. That knowledge really began to gain traction and led to a number of things. It led right away in New York City, within a couple of years, to policies to ban smoking in certain public areas, like parks and hospital parking lots and a few other areas, beaches. But it also began our understanding of the fact that multi-unit housing in urban settings is a place where we are exposed more to secondhand smoke because it accumulates. And the early findings from one surveillance system led to more targeted studies, so it advanced our knowledge in an area we hadn't really had on our radars, that urban settings put people by population density and by our built environment, it puts us in contact with secondhand smoke more. And so then studies came right on the tail of that, showing that, kids who live in multi-unit housing have more, who are in non-smoking households, have higher cotinine levels than kids who live in detached housing. So it's an issue. And now we have a ruling from HUD that is making all public housing go smoke-free. I mean, that's a continuous story. These aren't separate data points. And I think the same is true right at this moment around hypertension and hypertension management in New York City. A number of surveillance indicators are suggesting we're not turning the tide on hypertension. And so a lot of effort is going into programmatic work, policy work, to try to address this. Another data point that we acted very quickly upon when we understood how well we were doing at managing diabetes was we saw that New York City, on average, we were not prescribing insulin at the same level as the national. We were under-treating diabetes, and so we were not performing as well as the nation in managing diabetes. That was back in 2004. We have, based on this round of new studies, we have caught up. We've done better at improving our management of diabetes over time than the nation, which has been flatlined. So if we're not monitoring it, we don't shift gear.
Okay. Well, I have one or two other questions, but I think why don't we take some questions from the audience, and I'll save those for towards the end of our conversation. Does anybody have any questions? Yes. We have a microphone, so the folks on Facebook Live can hear us.
Thanks for your great overview of the incredible work that you're doing around the surveillance and the data analytics piece of it. My question is really about the next step, which you alluded to, which is the political viability, the financial viability of doing something about these problems. And I wondered if either one of you have some experience working with a certain type of provider where you've been successful at then going the next step and addressing the problem. Or if you weren't successful, what were some of the barriers that you encountered with that provider, and what do you think could be done differently to incentivize certain providers to address these issues?
So I'll go first. Okay. You're a provider. You've got the tougher issue here. I think it's really important to work at the ground level with individual providers and also work at the higher level with policymakers. And so some of the examples I just gave earlier were at the policy level, but another stream of work that we do, partners and I at NYU, is work with community providers in helping them understand their electronic health record and use it to manage their patient panels of patients with hypertension. And this is work that actually the health department does a tremendous amount of, and they do it through this PCIP team. And those of us in academia are testing comparable or alternate models of doing so. And in the context of small community providers, and this is just sort of a polar opposite to the policy intervention example I just gave, small community providers, it's very challenging. I mean, they are providing a lot of care in New York City. They're still very relevant to especially low-income communities. And they have, for the most part, adopted electronic health records, and they are trying to use those EHRs to improve the care that they give. And it's a mixed bag. And I think that's challenging for a number of reasons. But part of it is that the systems don't always work for them, and they need to upgrade and get a new platform, and then suddenly get new hardware and then software, and there are so many new demands on them to use this EHR as the vehicle that it could be to improve the care that they give and really get a bird's eye view of, are they managing hypertension well or not. It's still very challenging at the clinical provider level. That said, information back to them when they do know how well they're doing at managing a panel of patients really does drive their own behaviors at improving care. And I think that has been shown to be true. And so part of it is we're still many technical hurdles. Then their small clinical providers just have person power limitations. And so we need to identify solutions that work for small providers if we want to work in that realm.
Yeah, I guess in terms of my patient population, a lot of it is, a good number of them are in care, like they have a doctor, they have a provider, but a lot of the people who have some of the most difficult health problems are out of care, and they really use the emergency department as their only source of care. And so it's really hard to coordinate with ER doctors because we just don't think that way, and that's not how emergency departments are set up. I guess that's why my hope has been in more community-based interventions and seeing like if there can be a targeted community-based delivery of care. Like we're testing out ways of doing point-of-care testing in the community at community sites. So sort of this ancillary delivery of healthcare through a means that's trusted by people who may not want to go to a doctor or don't trust doctors. I would say just in terms of care coordination in general, I'm not an expert by any means in that, but I do think sort of the points that I sort of discussed in that, if you think about the most marginal patient who's very time-strapped, economically strapped, very has a lot of burdens, then it is about coordinating their care such that it's easier for them to be a part of the healthcare system. Because if you're, throwing them on, 4 different consultants on 4 different days, how could they do anything but access healthcare, So I guess that's my sense of it.
Another question? Yes, in the back.
Hi, thank you. My question is for Dr. Thorpe, and I'm just wondering about what the role, if any, of pharmacies can play in surveillance. You guys can monitor prevalence of things, but then are patients getting the medication they need? If it's prescribed, are they then picking it up and purchasing it? And I know in New York City, independent pharmacies are serving the low-income communities. So if those folks that might need a medication can't purchase it, are they tracking things like over the counter and other ways that they might be self-medicating?
Right. That's in the realm of an important data stream that I think more and more health departments are trying to have access to and understand, and the New York City Health Department has been doing that for actually quite a long time. I don't know what the current status is, but when I left the New York City Health Department in 2010 or 2009, late 2009, there was a contract with one of the largest pharmacy chains in New York City to receive electronic data on a real-time basis, meaning within 24 hours, to be able to look at over-the-counter sales of non-prescription drugs. And I think prescription drugs were in the works, and I don't know where exactly that is right now, but that was developed to initially in the context of syndromic surveillance to try and understand outbreaks that might be otherwise undetected or try to detect them earlier. and but both outbreaks that are naturally occurring and potentially, bioterrorism. And my health department colleagues might want to comment on that if they work in that area.
Just to speak to your point about the importance of independent pharmacies. Just to speak to your point about the importance of independent pharmacies, the bureau that we work for, the Primary Care Information Project, does have some ongoing pilots with community pharmacies because we do recognize that they're a really important partner for care in underserved communities. I think the pharmacy data is in the works, so we're on it.
Well, that kind of opens up another, interesting, just a thought that came into mind. Are there potential data sets or groups that we're missing or that should be included? I mean, we have pharmacists. Are there others that could also be tapped in order to make the database or a data set much more robust, that maybe next steps down the line?
Yeah, I mean, some of the limitations with the data I work with, it's all claims-based, and so you're left with diagnosis codes, procedure codes, but there's not a lot of laboratory data, which actually the Macroscope project has a lot of, and so I would say sort of that's like a level of like detail if we could coordinate like all the ERs to like basically provide, laboratory data. You could do some much more technical surveillance on especially conditions that are harder to track through claims data, like undiagnosed conditions, like chronic kidney disease and diseases that go largely silent. There's just, I would say that would be definitely a start in terms of health surveillance.
I would echo the laboratory data. And there's a lot of effort, and it's an uphill battle. It's really challenging at this point in time to make electronic laboratory reporting where it should be nationwide. So that is a major effort right now. It's about adequately equipping laboratories with the informatics systems that they need to be able to share their testing results, and then adequately existing the public health agencies to be able to receive and parse that information, as well as hospitals. Another realm of data that's very important and is being tapped with increasing frequency is social media. There's very innovative work being done to understand police-related violence by monitoring media and social media, and that's being validated by colleagues in Boston. There's work to try to understand outbreaks in just that much earlier through social media and social media responses, and using machine learning to be able to capture that information. I think there's really important and interesting work being tapped into by the FDA to try to understand adverse events. But this is in very early stages to be able to tap into when a device doesn't work well or a drug doesn't work well, to identify it that much earlier so fewer people are harmed.
Yes.
All right, thank you both for your presentations. I enjoyed both of them, and I actually do have Dr. Thorpe's paper. Been looking at it. I'm not going to refer to it, but I'm also an M.P.H. student at this time. I'm an M.D. and M.P.H., so I come from that direction. I'm doing some studying in informatics too, and in GIS, so thank you again. I was just wondering about the cardiovascular risk of the three factors that you considered, and how much overlap there is geographically. They cluster together physiologically, and I'm wondering if there's a need or if there's any effort to include hard outcomes as opposed to these surrogate markers, which we all know, and whether possibly physicians in a particular area could be alerted to their community profile, not just their individual profiles that they may receive from the information project. I'm wondering if that's a way, something that might be useful to proceed at another step.
Yeah, so in some ways we've taken that next step with our research, and we've actually asked, like, of the diabetic adults in New York City, what's the frequency of complications among them? And so we actually have a study that's out that basically assesses the prevalence of myocardial infarction, assesses the prevalence of stroke, prevalence of end-stage renal disease, and lower extremity amputations, the macro and microvascular complications of diabetes. And the maps are fantastic. They're so different. And it's every provider, every medical provider I show them to, like whether it be a nephrologist or a cardiologist, they're just stunned. Because in their mind, they're thinking, well, you have diabetes, so you're at risk for all these things. But the reality is the underlying geographic epidemiology of these conditions are vastly different in New York City. And basically, I think there are clearly behavioral and demographic issues and socioeconomic issues that drive those things. And so I can send you that study. You can basically see that the prevalence of myocardial infarction looks like an inverse map of end-stage renal disease in New York City. And so it's just startling.
Other questions? I have one that so if I'm a public health official from a rural community or one with limited resources, and I'm watching this on Facebook Live, let's say, and I get very excited because I sense this is something that I really, really need to do for my community. But then there's a question is, would I be able to tap those type of resources for the macroscope or tap the resources that you're doing for Sullivan County? I guess I might be jumping ahead as far as your work, David. But I mean, is this something that a technique or a technology or a model or a method that's actually affordable if I have limited means?
Yeah, so I'll address that in terms of the emergency department surveillance. I mean, it can take a bit of time, but basically a lot of New York providers, whether they be healthcare institutions or public health centers and institutes, basically can access the emergency and inpatient Sparks database, which is the database I use. Frankly, when this process started, it was just me doing all this geocoding of address data throughout the state. And what I would say to that point is we're starting in Sullivan County because they basically have some of the most desperate health needs that we assessed when we were looking for a partner. But the reality is that if we show that this surveillance technique can work in a rural county like Sullivan County, I mean, by tomorrow, I can produce a map just similar to what you saw for every single county in New York State. And not every state in the U.S. has address-level data. Some do, some don't. But I would argue that even zip code-level data would be incredibly important for a number of states to be able to identify. In New York, you have a lot of more cluster and density, so it's better to parse out by like census tract and XY coordinates. But in like more distributed states, it could be much more different. I think sort of what we already talked about, which is like how do you take that next step, is kind of a challenge that we talked about at Epidemiology, Lorna and I talked about with other people around the country, which is like sometimes the most difficult thing is like I can produce a map very easily to tell you where the problems are, but what's the next step? And I would say for public health agencies that are struggling, I would say, one issue is that if you found interventions that work, you could geographically target them to the areas that have the most need. So that would be one way of maximizing the resources that you have to intervene. Another thing that I've just noticed in working with Sullivan County is that there's a lot of pressing health issues that these counties are facing that they just need more data for. And we're trying to supply that. I would say the elephant in the room, which is basically since Sullivan County has, a poor and often predominantly white and Caucasian population, as if you've been tracking what's been going on, the opioid epidemic is disproportionately affecting people in those counties. So we're starting studies because that's what they asked us for. I mean, we didn't expect to go down that route when we were funded by the New York State Health Foundation. We were really like diabetes, hypertension, asthma, but when the partner asks you and say, hey, this is really the problem that is at our hearts and we're seeing this, then we have to respond and trying to work on that, or at least making the first steps.
Just going back to your question of is this viable for another jurisdiction with potentially fewer means? Part of the effort that we've put into Macroscope, and I really, again, credit my health department colleagues here, from the get-go has been to do validation work and to build on what other validation exists in other countries. It's mostly in Canada and Europe, but beginning here in the United States, to build on a body and add to that knowledge so that some jurisdictions can say, okay, according to Macroscope, according to the 5 to 6 other systems that have tested it, hypertension is measured well in electronic health records because blood pressure is measured at every visit. So we don't need to validate that locally. And so in addition to doing the validation work that's published in peer-reviewed manuscripts that maybe 1 out of 50 people here would read, the health department has led the development of, I'm pointing to some hard copies here, of indicator fact sheets that are available on the New York City Macroscope website or will be soon. We also have hard copies here for anyone who's in the room that would like it to take those. And what they basically say is, how well did this indicator work? And put it in the context of literature as well. And here's the definition. So you can pick it up and employ it. It's still hard work for building electronic health record surveillance system. You need the analysts that can do that type of coding and programming. You need the people who can guide it and interpret it. But I think the validation work doesn't need to be done.
Any questions? Because then I'll ask my what I call the really big elephant question. Well, I do have I have what I call the really big pink elephant that's in the room, and I think since January of 2017, a lot has changed, and I'm wondering, with your work, which has started well before the change of administration and the change of the whole political and budgetary landscape, and now with the Repeal and Replace Act, at least with the House, has been passed, and obviously there will be changes once the Senate gets their hands on it. What does that mean for your work? I mean, and what does that mean for, in specifically, but also in general with population health surveillance? I mean, it seems that there will be a lot of the priorities as far as health is concerned has been changed, and then consequently the funding that many folks have been relying on will probably change as well. So it would be interesting to hear your thoughts on that.
I have a simple answer. I think more than ever, surveillance is critically important at the local level. It's going to tell us what the impacts of this is, and we need to understand that in a very granular detail. Will Repeal and Replace worsen disparities in disease management, for example? We won't know that unless we have systems like this to be able to tell us what's happening at the local level. So that's my simple answer. Does it impact our funding streams to be able to do this? Of course it does, but I think that there are, potential solutions, new partnerships, collaborations, funding streams, whether it's tapping into big healthcare dollars for this purpose. That's one potential solution. But I think my bottom line message is surveillance at the local level more now than ever.
So I'll start small first, but Lorna and I talk about this in terms of surveillance, and one of the biggest things is bias and threats to validity. And so I'll speak to the methodology issue, which is, there's this misconception that I'd like to just address, since I'm somebody who studies emergency department use intensely and by demographics and socioeconomic factors. The reality, just published research, even some of my own, is that somebody who does not have health insurance is not much more or not at all more likely to use the emergency department than someone with private insurance. The difference is if somebody has Medicaid or Medicare, they are much more likely to use emergency departments. And so there's good research that shows that when there was implementation of expansion of Medicaid through what's known as the Affordable Care Act or Obamacare, there was an increase in emergency department use. And so, those trends do affect what we see in the emergency department data because it is suddenly an influx of people who are using the emergency department more frequently. And so there are these, things that are difficult to control about what naturally happens with the surveillance. And when a major change like that happens in how people access emergency care, the reality is that you can't necessarily compare year to year or longitudinal changes. What I would say, I agree totally with Lorna in that, with basically fewer people being insured, I think we'll see people accessing care less, and that's going to have impact. And I know for the people that I see that don't access care on a regular basis or don't have the means to, it's very difficult. And it has a real impact on their lives, regardless of what is in the media.
Great. Well, thank you very much. This was very educational for me as well, and I hopefully for everyone who's been watching. Just a round of applause for Lorna and David. And just and finally, a lot of the documents that have been handed out here in the room, we will have them posted on the website, along with the recap as well. So for those of you who are wondering what we're referring to, you'll have access to that as well. And thank you for coming.
Thank you.